It is 6 p.m. in Paris, 9 p.m. in Abu Dhabi, and it is my great pleasure to welcome you all to this ICH webinar on advances in thalassemia management. This is the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to moderate this very special webinar where we will explore the latest advances in thalassemia management as presented, at least in part, at the last ASH 2024 annual meeting. As we all know, thalassemia care is rapidly evolving with significant advances in gene therapy, but also some novel innovations and personalized care strategies. And today we have the privilege of hearing from a top expert in this field, namely Dr. Farrukh Shah, who is a consultant hematologist currently in Abu Dhabi. She obtained her MD from the University College London, focusing on iron overload in hemoglobinopathies. And she held different consultant positions in the UK, and she also was the chairwoman of the UK Forum on Hemoglobin Disorders and the National Hemoglobinopathy Register. So, as you would imagine, we have the right and top expert in this field, and we're very honored having you with us, Dr. Shah. And I'm sure this session promises to be an insightful one. And we'll have some live Q&A at the end, trying to bridge research with real-world practice. So again, a very warm welcome to all of you. This is the ICH. Thank you for joining us, and let's begin. Dr. Shah, the floor is yours.
Thank you so much, Professor Moti. I'm very honored to basically talk on my take on the ASH abstracts. These are just my disclosures. So having gone through the ASH abstracts, I'm going to keep it very simple because I am quite a simple person. I'm going to give some updates on basic science and innovation and really talk a little bit about new things that may be coming in to the clinical arena for thalassemia patients, potentially. And then I'm also going to talk about any improvements that have happened that have been presented at ASH on management options for patients with thalassemia. And then I'm going to end up with clinical trial updates with some of the longer term cohort data being presented at ASH this year. So thalassemia, as we know, is a chronic inherited anemia. It's a lifelong disorder. Patients are totally dependent on regular blood transfusions. They develop iron overload and therefore need iron chelation therapy. And it's very important that we monitor patients for complications and iron overload. In the Western world, outcomes are extremely good with standard of care in expert centres. And this is data from the Italian registry, which was published by Gianluca Forni in 2023, showing excellent survival in the Italian cohort. Now, as we know, the path to innovative therapies is a very, very long one. And this is just a diagram of how long it's taken for us to actually get innovation into the thalassemia field. So we're going to talk a little bit about innovation. And there's one molecule that I think, well, there's several molecules that were presented, but this particular one I think is very interesting. This is a molecule called AND017, and it's a hemoglobin elevating agent. Now, the mechanism of action for this is not fully worked through, but was identified as a potential drug for improving hemoglobin levels through traditional medicinal chemistry approaches. And data that's been presented very recently from the Towns mouse work, and this was presented at ASH, shows that this molecule actually promotes glycolysis and enucleation and mitophagy, as well as terminal differentiation in leukemia cells. And in the sickle cell mice, this product actually promoted terminal differentiation of erythrocytes and reduced the mitochondrial retention in reticulocytes and mature red blood cells, which prolong the life of the red blood cells. So this potentially may be very effective in patients with thalassemia syndromes. It has actually been granted orphan drug status because it has been shown to improve anemia in patients with kidney disease, with two big studies happening looking at safety and efficacy in non-dialysis dependent and dialysis dependent patients. And these patients responded very well to this therapy. So the data from ASH actually looks at the use of AND017 in thalassemic mice model, and they basically give 22 mice the drug in different doses, and one cohort of mice get the control. And what you can see here is that there's a significant improvement in the hemoglobin levels in mice that have been exposed to 10 milligrams per kilogram and 15 milligrams per kilogram of AND017. And these mice were dosed daily for 42 days. As you would expect, as the hemoglobin improves, you would expect the total red cell count to improve, and this was shown in the mice, and the hematocrit also obviously improved. The morphological examination of the blood films in these mice also significantly improved, and other markers of stressed erythropoiesis, for example, low body weight, improved in the mice that were exposed to the higher doses. So this potentially, having already been tested in humans in renal failure, is likely to move fairly quickly, I think, into clinical studies for both sickle cell disease and for thalassemia. And it would be very interesting to see what happens with this molecule. There's another molecule, well, actually, there's two different mechanisms of action that are being investigated by both Novartis and Bristol Myers Squibb. And this data was presented at ASH. And the data that I'm going to be talking about is based on the ZBT7A and the Wiz dual degrading molecule, which is being investigated by Bristol Myers Squibb. So during effective erythropoiesis, ZBT7A is activated by the GATA1, and this directly binds to the pro-apoptotic BCL2 factor, inhibits transcription and suppresses red cell erythropoiesis and ensures the final production of erythroid cells. The Wiz protein is a chromatin-associated transcription factor that localizes to promoters and enhancers. And there's evidence that Wiz is a putative hemoglobin F gene controlling mechanism that represses hemoglobin F expression. Now, Wiz is involved in the late stage differentiation of erythroid cells, and ZBT7A is also involved in the late stage differentiation of erythroid cells. Now, this molecule is currently being investigated as a dual degrader of ZBT7A and Wiz, and is being investigated by Bristol Myers Squibb. The product that's being investigated by Novartis is looking at Wiz degradation only. So SH6 is known to downregulate both ZBT7A and BCL11A, which are both two known gamma globin repressors. And gamma globin induction in this particular abstract was assessed by qT-PCR, flow cytometry, and HPLC. They also looked at the mechanisms of action, looking at a variety of different modalities for this. This data wasn't included in the abstract, but they also looked at synergistic effects with other disease-modifying agents, such as hydroxyurea, decitabine, and pomalidomide. Now, treatment with SH7 led to a 6-fold increase in gamma globin expression in HUD-EP2 cells compared to DSMO without causing significant toxicity or erythroid problems. And in healthy donor CD34 stem cells, SH6 induced significant increase in hemoglobin F without affecting differentiation, and also effectively downgraded ZBT7A, BCL11A in a proteasome-dependent manner within 24 hours of exposure. The synergistic effect was very interesting because what they saw was a 4-fold increase in mRNA expression compared to SH6 alone with decitabine, and a 9-fold increase compared to decitabine alone. So potentially opening the door for synergistic utilization of drugs like decitabine with this particular molecule. The other very interesting thing about SH6 is that this is also the first molecule that's been able to show activation of other forms of globin, epsilon and zeta globins, and therefore potentially widening the use of this agent in other types of thalassemia syndromes. So those are the new molecules that are potentially going to make their way into phase 2 clinical studies for thalassemia patients. And we're going to move on to clinical, because I am totally clinical. And I was very excited to see Rafaela Arriga's data on pregnancy, because we've literally just published the British Society of Haematology guidelines on the management of pregnancy in thalassemia patients in the autumn of 2024. So this is the single largest cohort data for outcomes in pregnancy worldwide in thalassemia patients. And they looked from their registry at 341 pregnancies in 247 women with transfusion-dependent thalassemia. And 74 of these women actually had 2 pregnancies, and 18 had had 3, and 2 had actually gone on and had 4 babies. The age at first pregnancy has, of course, significantly increased over time, and this is based on most women in the Western world actually choosing to have babies later on. Ovulation was induced in 131 patients out of the 311 cases, and was spontaneous in 180 patients. So that's really good, because it means that hypogonadotrophic hypogonadism is reducing in patients. Conception was actually spontaneous in 225 patients. So even patients who needed ovulation induction were successfully able to conceive naturally. And only 30 patients actually needed intrauterine insemination, or 45 patients needed IVF. So this is extremely good data. The rate of natural conceptions actually significantly increased over the years, and the risk of assisted conception is higher in older patients, as you would expect, because many of these patients were very heavily iron overloaded as young people, and therefore have complications as a consequence of iron overload. Pre-implantation diagnosis was performed in 12 because of high-risk couples, so that's a thal major woman with a beta thalassemia trait partner. And 9 miscarriages actually happened. The rate of spontaneous abortions was about 9%, and the percentage of complications during the pregnancy was actually the same as the general population, which is, again, very, very good. Now, cardiac concerns are the main reason why we're very anxious about thalassemia women as they move into pregnancy. And out of 104 patients that they had in their registry that had had cardiac T2 star assessments, only 8 had moderate iron overload and 4 had severe cardiac iron overload. After 2015, none of their patients have had cardiac iron overload, and they've all gone through pregnancy with T2 stars above 20. Again, reflective of better monitoring and better management of cardiac iron overload in patients and pre-pregnancy optimization. So both pre and post-pregnancy T2 star values have increased significantly over time. And 72 women with pre-pregnancy cardiac T2 stars, which were above 20, who also had postpartum scans, 11 showed moderate accumulation and 1 actually showed severe accumulation. So that means that the majority of women in the Italian registry did not accumulate iron in the heart as a consequence of pregnancy. This is very similar to what we've experienced in the UK, that cardiac iron overload is not that common if you pre-optimally optimize your patients pre-pregnancy. Of those 12 patients that did show cardiac accumulation, 4 of them had actually had really low liver iron burdens pre-pregnancy, so they had been really well optimized. 6 had LICs between 2 and 7, so again, really pretty well optimized, and 1 had an LIC of above 7. So overall, pre-pregnancy liver iron concentrations haven't changed over the years, and 19 women have gone through pregnancy with pretty severe liver iron overload. Only 2 patients out of the entire cohort experienced cardiac failure. 1 was immediately postpartum in 1990, so this is even pre the cardiac T2 star monitoring. And the other patient was following a twin cesarean section delivery after a long period of time of poor adherence. There was 2 stillbirths, and of the 245 pregnancies, 26 of those pregnancies were twins and 3 were triplets. Now, the thing that is discrepant from the UK data set, which is obviously much, much smaller, is the amount of cesarean deliveries in these patients. 181, that's 77% of women actually had planned cesarean sections. And this is in contrast to the UK data set, where majority of our patients actually successfully managed to deliver vaginally. 37 of the pregnancies were emergency cesareans, and the number of cesareans hasn't changed over time. So women are still choosing to go for cesarean deliveries. 97 babies were born preterm, and 132 were born at term. And preterm births have actually decreased over time. And this is, again, probably as a consequence of better monitoring. 2 patients have received luspatercept during the pregnancy in the early stages without any complications. And a significant number of patients have actually been exposed to iron chelation either in the early trimester period before confirmation of pregnancy, and none of their exposures have resulted in any kind of fetal anomaly. So that's the pregnancy data, which I do think is actually really very important. I'm looking forward to a paper being published by Raffaella on this. One data set that's caused me a little bit of concern was the presence of myocardial fibrosis in non-transfusion dependent alpha thalassemia intermediate patients. And this is data from John Wood's group in California. So, but it is a small cohort, so I think it has to be interpreted with some degree of caution. They did look at extracellular volumes, and this was measured by MRI scan, pre and post gadolinium enhancement. And they had thalassemia intermediate, alpha thalassemia intermediate, and they had E-beta thalassemia and beta thalassemia patients. These are the numbers of patients, and they varied from the ages of 2 to 63 with a median age of 27. Out of the thalassemia intermediate patients, the alpha thalassemia intermediate, only 3 were transfused, whereas all of the other cohort of patients were transfused. And what they found was that the extracellular volume, as measured by MRI T1 and T2 mapping with the gadolinium enhancement, significantly increased with a falling hemoglobin amongst all patients. So that's the transfusion dependent and the non-transfusion dependent. And extracellular volume was increased with age in all patients. And so hemoglobin and age were both important in this particular cohort of patients. So I think we need more data to really look at the thalassemia intermediate alpha HbH patients to see if they do develop significant myocardial fibrosis as time goes by. Now I'm going to talk about transplant and curative therapy, and the take home on this is I am most definitely not a bone marrow transplanter, but the data has been actually really quite exciting and very good. So I'm going to present some basic science data, and hopefully I'm not going to make a dog's ear out of it. But I thought that this particular data was really very interesting, and this is abstract 516. And the reason this is interesting is that the biggest problem with gene therapy is the use of busulfan and myeloablative chemotherapy, which prohibits the use of gene therapy in a significant number of patients. And if this technique and technology works, then this is going to open the door to non-myeloablative conditioning. So what they did was they looked at, what this group has done is they looked at non-genotoxic conditioning strategy using engineered stem cell antibody paired evasion, or an escape approach. And what they did was that they epitope engineered CD117, c-Kit, basically, with a base editor. And the aim was to retain normal CD117 receptor function, but for it to escape recognition by a cognate monoclonal antibody that actually recognizes wild type CD117 and therefore could be used in conditioning. The escape CD117 edit was combined with a therapeutic target edit in the gamma globin gene promoted to induce high levels of hemoglobin F. And the escape approach actually enabled the elimination of the toxic effects of myeloablative chemotherapy in the rhesus monkey when they tested it. So what they did was they actually used rhesus macaque monkey, which they exposed to an autologous transplant using the CD34 stem cells. So in the first monkey, they mobilized CD34 stem cells, and they were multiplex edited for CD117, and hemoglobin F levels were confirmed in the cell product. And what they then did was they successfully engrafted one animal with a busulfan conditioned transplant, which resulted in a 98% hemoglobin F production and 88% gamma globin levels. They then employed the escape technique on 2 additional rhesus monkeys and exposed them to 10 milligrams per kilogram or 25 milligrams per kilogram of CD117 monoclonal antibody prior to the transplant. Post-transplant, they gave the monkeys additional monoclonal antibody treatment to give a competitive advantage, basically, to the actual product. Monoclonal antibody was very well tolerated at both doses in both of the monkeys. And what's very interesting is that the hemoglobin F levels rose to 61% in the periphery by 8 weeks post-transplant. And both monkeys actually had stable hemoglobin F production at about 85% at week 35. So both monkeys effectively producing high levels of hemoglobin F following a CD117 escape method transplant. So potentially providing hope that we will move to a non-myeloablative conditioning regime at some point in the future. So transplant again, and this is EBMT data, looking at 10-year cohort data. And basically looking at GvHD and event-free survival. So GRFS, which is defined as the absence of GvHD and good event-free survival. And they looked at 2,807 patients. And this is basically data that I pulled together from the abstract. And what you can see here is that 2,600 of the transplants were actually in children below the age of 18, 206 were in adults. And the majority of these patients were matched related transplants, with a small proportion that were unrelated and a smaller portion that were mismatched related. Overall data was really very good. So overall survival was 92% in the children. Event-free survival was 87%. And grade 3 to 4 GvHD was only seen in 8.4% of the children, 9.5% of the adults. Now, multivariate analysis basically showed that as age increased, the hazard ratio for graft associated problems and GvHD increased in patients as they got older. So very important that we should be aiming to transplant patients as young an age as possible. The other very interesting transplant data, I think, has really come out of the Chinese group. So there's a couple of abstracts that I'll be showing, which are specifically from China, looking at outcomes in patients who've been transplanted there. Now, in this study, they actually looked at the use of dacilizumab at a dose of 1 milligram per kilogram per day as GvHD prophylaxis, in addition to standard GvHD prophylaxis. And they administered dacilizumab on day 7, 14, 28, and 42. And this is in addition to the standard prophylaxis that they use, which is tacrolimus, methotrexate, and MMF. And the transplant conditioning was the same in all of the patients. So they used busulfan, bucyfludarabine, and ATG as the transplant conditioning. The other additional thing that the patients that received dacilizumab received is that they received letermovir as CMV prophylaxis in that cohort of patients. And what you can see from their data is that there is a significant improvement in GvHD in patients who are receiving dacilizumab, with only 5.9% getting grade 3 to 4 GvHD. Now, overall survival and event-free survival was extremely good in the patients, mainly because as soon as they recognized GvHD, they initiated additional measures. But there was also a decrease in the CMV reactivation rate observed in the dacilizumab group because of the use of prophylaxis. And the cumulative rate of all the other complications was the same across both groups. So potentially really useful data in patients going for transplant. So clinical trial update data has been presented at this ASH, and luspatercept is an agent that's been around for quite a long while now, and we're all very familiar with it as an activin receptor ligand trap. It's pretty effective in thalassemia patients. It was used in the BELIEVE clinical trial, which was a placebo-controlled randomized clinical trial with an open label 5-year long-term follow-up, and all the patients who were on the placebo arm actually moved into the treatment arm as part of the long-term follow-up. And this data actually presents long-term follow-up data for patients going up to 5 years. So they looked at serum ferritin, liver iron concentration as measured by T2 star, and changes in iron chelation therapy for patients over time. And they looked at the luspatercept group who'd received luspatercept at the beginning and the crossover group. And the median follow-up was actually 303 weeks in the treatment luspatercept group and 268 in the placebo group. So at the data cutoff, they had 111 patients were still undergoing treatment with luspatercept, and 72 patients were in the luspatercept group and 39 patients were in the crossover group. And what you can see here is that there's a significant number of patients that actually have their ferritin fall below 1,000. So even though the overall ferritin has only gone down by 374, you have more patients moving to ferritins below 1,000. The liver iron doesn't change significantly, but the liver iron is actually really very good anyway, even at baseline. However, this is associated with a reduction in chelated dose because clinicians were given leeway to reduce the chelation dose as the ferritins went down. And you can see that the chelation doses do decrease over time. What's interesting is that in the luspatercept group and in the crossover group, there continues to be a reduced requirement for blood going up to 7.4 units over a 48-week period in the luspatercept group. So mitapivat is a PK activator. It's a very exciting drug and has been presented as part of the ENERGIZE study looking at non-transfusion dependent patients at EHA. And this is the data from EHA, which basically shows that mitapivat improves hemoglobin in patients with various different types of thalassemia intermediate, that's non-transfusion dependent patients. And this includes alpha thalassemia intermediate patients in the treatment arm. So the results were really exciting in this particular group. And at ASH this year, they presented data in the ENERGIZE T group, and this is the patients who are transfusion dependent. So they had 258 patients in the study, 171 received 100 milligrams twice daily of the drug. And the average age of patients was about 35. There's no relationship between various demographic categories and effectiveness of mitapivat. And I just want everyone to really focus on response rate. So they defined transfusion response as being a greater than 50% reduction in transfused red cell units, or a reduction of more than 2 units of red cells in any consecutive 12-week period. What you can see here is that 30% of patients who are transfusion dependent met the primary endpoint, which is a significant reduction in transfusion requirement. And then they had further reductions in transfusion requirement in a number of these patients. And you can see that 9% actually became transfusion independent. So this data is really exciting, very promising for thalassemia patients. And this included thalassemia beta, but also included alpha thalassemia transfusion dependent patients as well as part of the study. So gene therapy is obviously very important innovation for patients with thalassemia. And we are all very familiar with the beta B globin gene automicelle study, which had groups A, B, and C. And they had modifications undertaken in their processing and manufacturing, which meant that patients who were in group C got higher vector copy numbers. And this data that I'm going to present is for 2024, but this is data that was presented in 2022. Which basically showed that a significant number of patients got very good hemoglobins and transfusion independence. So they now have data on 63 patients in the long-term follow-up, and the follow-up has been between 2 and 10 years. So this very long follow-up. 51 patients actually have more than 5 years follow-up. Vector copy numbers have remained stable throughout, and HbA-T87Q has also remained stable throughout this period of time. And in the transfusion-independent patients in the 2 cohorts, phase 1-2 patients, they had a hemoglobin level of 7.6 of 87Q, and the patients who were in phase 3 had a 9.8, so almost a 2-gram increase in the hemoglobin levels. Now, the 3 participants who achieved transfusion independence, 78% of patients are no longer receiving iron chelation therapy, and transfusion independent patients have had a very significant reduction in their serum ferritins over time, as you would expect, and liver iron has also dramatically increased, and cardiac T2 star has normalized. So this is really important because it's showing that the transplant has effectively been curative. And what's also important is that health-related quality of life is measured by the SF36, both in the adults and in the pediatric setting, has shown significant improvements in health-related quality of life in patients who've had beta cell transplants. Vertex has also presented their gene therapy long-term follow-up data, and this is data which was presented by Franco Locatelli at ASH in 2023. And the data that's been presented this year is an update on that data, and they now have data on 52 patients, and 49% of those patients, 49 of those patients have received transfusion independence for a period of greater than 12 months. But what I want everyone to take home today is that the 3 patients who did not achieve transfusion independence at 12 months actually have achieved transfusion independence, albeit later, with 2 patients becoming transfusion independent at 14.5 months and 12.2 months, and 1 patient becoming transfusion independent at 21.6 months. And that patient actually needed a short period of transfusion to cover a gastrointestinal illness, but has now been transfusion-free for almost 5 months. So this is really promising. So even if a patient doesn't become transfusion independent post-transplant, they may become transfusion independent a year or a slightly longer later. And what we can see is that health-related quality of life has really improved in these patients, and iron burden, again, as you would expect, has decreased dramatically in these patients. Now, obviously, Beticel and Exocel have been investigated in the UK, Europe, and in the US. But the Chinese group have been very active, and this is the same Chinese group that looked at the earlier study that I presented looking at GvHD. And they've been working with a molecule called RM001, which is again a CRISPR-Cas9 BCL11 targeted product, very similar to the Vertex product. And they've transplanted successfully 19 patients. And they've also looked at transfusion independence at 12 months and at 6 months. And they've used a variety of patients, so patients with beta 0, beta plus, and beta plus plus mutations. All of their patients have actually become transfusion free within 6 months of the transplant. The time to engraftment has been very good at 15 days and 21 days for platelets and neutrophils. And most of the patients actually stopped blood transfusions roughly around day 22 post-transplant. 9 patients have had more than 15 months of follow-up, and they've all been transfusion independent for a period of 12 months. So this is really promising because it means that we will have greater access to CRISPR-Cas9 gene-edited transplant products as time goes by, because we would expect the Chinese product to also come to market, and hopefully competition will lower the cost as time goes by. And patients are getting very good hemoglobin levels, with a hemoglobin level of about 11.5 to 12 in the majority of the patients. Now, my final slide is looking at the alpha thalassemia cohort. So this group has also done gene editing to look at hemoglobin constant spring, which is a single gene point mutation. And they have successfully managed to edit this using a cytosine base editor, and successfully transplanted 1 patient with hemoglobin H constant spring who was transfusion dependent, needing 29 units per year. And she is now transfusion independent. Now, we've not been able to offer really proper good quality gene therapy strategies for patients with alpha thalassemia, but this now opens the door for this population of patients. So I just want to say thank you very much for listening to this very rapid fire talk on slides from ASH. I'm very happy to answer questions, but please do remember that I'm not a transplanter. You can ask me about thalassemia.
Wonderful. Thank you very much, Dr. Shah, for really a beautiful and a very comprehensive overview about the state of the art in thalassemia. So we have 6 minutes to take a few questions, and I'll start with the diagnosis. And we have a question about whether there are specific populations where screening for thalassemia is recommended. What is your current approach?
So I think it's incredibly important that we do. In the UK, we do newborn screening. We don't have premarital screening, although Cyprus and other countries have implemented premarital screening. I think in the Western world, where the population of thalassemia carriers is really quite low, we need to have a targeted approach to testing, and that needs to be driven by education and awareness of the affected populations. I think in countries where there's a much higher prevalence, so I'm currently in the UAE, there's a high prevalence, premarital screening should be done, because prevention, thalassemia really is a disorder that, you know, you can successfully prevent, and we should be encouraging that. There are some really interesting presentations at ASH this year looking at microchip testing for sickle cell disease, but that's also equally applicable for thalassemia, and that will eventually lower the cost of testing for and allow bulk testing for these high-risk populations.
Wonderful, thank you very much. We have another question about actually indications for transplant. Is there an age limit or a specific contraindication where you would not refer patient to transplant?
That's a really, really good question. So we recommend all children with a matched sibling are transplanted as early as possible, ideally before the age of 5, but, up to the ages of, 18 generally. The younger the patient is at time of transplant, the better they're likely to do, especially if they do have a matched sibling. There are families where, because chemotherapy is genotoxic, potentially associated with fertility problems, there are families that absolutely do not feel that they are in a position to make that decision for their child. And that's a very reasonable position to take, and is a condition, is a state where everyone really thinks about this. So I think very open discussions about fertility rates is really important. My own experience is that the younger the child is at time of transplant, the less severe the fertility problems. They're more likely to go through puberty naturally. If you're being transplanted when you're going through puberty, you're highly likely to end up infertile. But the potential is that you're more likely to be able to sperm bank if you're a boy. With girls, we should automatically now be offering fertility preservation using all of the techniques, ovarian tissue cryopreservation, etc. I think the situation's vastly different to what it was 5, even 10 years ago. We do have better options, and we should be offering it.
Excellent. Thank you very much. So you have mentioned several novel agents maybe to try to increase hemoglobin level. And we have a question whether luspatercept is a good candidate to increase hemoglobin level.
I think that's a good question, in that we've had 5 years worth of data in patients, and certainly in the non-transfusion dependent patients, the hemoglobin does go up. In the thalassemia major patients, my take on this is that it really doesn't put up the hemoglobin to a significant enough degree to render these patients transfusion independent, or actually even to significantly reduce transfusion requirement. It's only 33% reduction at the best in a small population of patients. Mitapivat, on the other hand, is providing a 50% reduction in transfusion burden for patients based on the data that was presented at ASH. So potentially, I think as time goes by, we will see better quality, more efficacious drugs becoming available. And if a drug is given orally, it's going to be a game changer for the patients. Because nobody likes having injections, and an oral medication will make a massive difference.
Excellent. Thank you. We have a question about ion chelation. What is the current protocol or standard of care you would recommend?
So I would strongly recommend that people look at the British Society of Haematology guidelines on monitoring of iron overload and ion chelation, and also at the UK Thalassemia Society guidelines, which were published in December of 2023. There's no one formula for all patients. And I think it's really, really important that we move away from a standard protocol and actually start to develop treatment plans which are very patient-specific and patient-centric. Every single drug has side effects. Every single drug has got different tolerability profiles for patients, and sometimes one drug is not enough for a patient because they get terrible side effects, but they can tolerate half the dose or a quarter of the dose. And I think it's beholden on us as clinicians to really target chelation, because this is the mainstay of a patient's survival. And we need to target chelation based on what the patient can actually do, not what we think is best.
Thank
And
you.
that's actually reflected in the guidelines.
Absolutely. Thank you. So we would invite everybody to have a look into these important guidelines. One last question, which I believe is more a philosophical question. What would be your personal opinion regarding the different gene therapies being developed or available, and are they all equal, or where do you see the future?
Now, that is definitely a difficult question. So I'll just put a disclosure down. 4 of my patients were cured as part of the Vertex clinical trial with exa-cel. One of them has been cured as a consequence of the Beti-cel gene therapy. So they all work. Okay, so that's the really important take home on all of this. They all work. I think the phase 3 cohort with the better manufacturing for Beti-cel is very good and works. I do have to say that I am slightly biased towards the CRISPR-Cas9 gene editing. We have seen really fantastic improvements in hemoglobin levels in patients. I do understand that pharmaceutical industry has to recuperate its costs. I sincerely hope that as time goes by, that number one, the drug cost becomes cheaper, and number two, and this is absolutely critically important, that we move towards a non-myeloablative conditioning regime for patients, because this will open the door to many patients actually then accessing treatment. At the moment, I have patients telling me, no, thank you, I'd like to have my babies naturally. Is what they tell me, because it's such an important thing for them. And we have to also remember that thalassemia is an ethnic minority disease. And in these populations, similar to sickle cell, the fertility of a patient, of a person, is actually very important and reflects their role within their society, within their culture. And you know, the cure is not always everything. I think that's important to remember.
Wonderful. Thank you very much. Thank you all for joining us into this insightful session on the latest advances in thalassemia, as presented at ASH 2024 annual meeting and beyond. I think the progress in treatment strategies brings renewed hope for patients worldwide, and that's really amazing. We do appreciate our expert speaker, Dr. Shah, for sharing her knowledge, and of course the audience for their engagement. Let's continue our educational efforts. Let's continue to collaborate together. Let's continue to innovate together in hematology. Wherever you are, please stay safe and keep well. This is the ICH across the hematology field and around the globe. Thank you.